Now, Executive Suite with WPRI.com reporter Ted Nesi.
With 600,000 members and more than $1.5 billion in annual premiums, few insurers dominate a market more than Blue Cross and Blue Shield does here in Rhode Island. Yet today, Blue Cross is facing new challenges as change sweeps across the U.S. healthcare industry. The insurer's executives are facing pressure to hold down costs, even as they still need to replenish their cash reserves post-recession. Meanwhile, Rhode Island's new HealthSource RI marketplace is counting on Blue Cross's cooperation and coordination to get Obamacare up and running in the state. This week on Executive Suite, a look at the brave new world of health insurance with Blue Cross and Blue Shield of Rhode Island CEO Peter Andruszkiewicz. That was pretty close to saying your name, I think, Peter.
Not bad at all.
I want to welcome you to Executive Suite. We were talking before we got on air here that I think Peter may have the longest surname of any Executive Suite guest in history so far on the show. So welcome. And I think I said it right there, so it's good to have you here. And we have so much to talk about, as I said in the opening package. But before we dive in, I want you to just explain something for people at home that it took me a long time to understand, which is there are Blue Cross and Blue Shields all over the country, right over the border in Massachusetts, but you're not one big corporation with subsidiaries, right?
That's correct. And a lot of people are confused about this, Ted. And, today there are 38 Blue Cross Blue Shield licensees. So Blue Cross Blue Shield Rhode Island is a franchise, if you want to think about it that way. And we are a licensee of the Blue Cross and Blue Shield name, or one of 38 plans. There used to be over 100 Blue Cross Blue Shield plans. There's been a lot of consolidation. So we share the name. We agree on certain elements of care for each other's members. So if our members, a Blue Cross Blue Shield Rhode Island member, goes to Florida for the winter and they need care in Florida, the Blue Cross Blue Shield plan of Florida will provide that care at the discounts and at the service level that the plan arranges for down there for our members, and vice versa.
But you don't report to some Blue Cross CEO who said you're a division or something. No. You're independent and you license out of
There's
that.
a Blue Cross Blue Shield Association. It has a president, but it works for the plans. And I'm on the Blue Cross Blue Shield board, as are all the other 38 Blue Cross Blue Shield CEOs.
Gotcha, which is different from United Healthcare, for example, which is a big company and all that, yeah. So let's talk about first how Blue Cross Rhode Island is doing financially. Obviously, the economy around has been pretty abysmal. You had a net loss of $42 million in 2012, you reported in your annual report, and your reserves were lower than the state's recommendation. How is 2013 shaping up as we get to the end of the year? Are things looking improved for this year? What are you expecting?
2013 is a much improved year, and we've had improvements because of better cost trends in medical care and health care overall. We've had improvement in costs because we've continued to work on our administrative costs. We've had improvement in costs because we've improved our the care costs for our members as well. We'll make a contribution, a positive contribution to our reserves in 2013 of somewhere between $25 and $30 million. And that's the first time the company will make a contribution, a positive contribution, since 2007. So it's a big deal, and it's a good thing for the company.
What's driving, or was driving, in particular, the financial challenges that led to? I know that 2012 reserve lower was a big concern among the executives at Blue Cross. It
was, and so when a not-for-profit company loses money like ours, there's no place to get that money except from the company's reserves. The reserves are really there to protect the company and its subscribers in the event there was a big weather event, which you could have in Rhode Island. There was a pandemic, which is ultimately possible, and to protect all of our members in the event that something like that were to happen. When the company loses money, it has to go to those reserves that continue to operate. So over the past, since 2007, the company's reserves were used to the tune of about $150 million, and we were concerned. Today, the company is not in danger by any stretch of the imagination. We have actuaries come in and say, what's the safe zone for our reserves? It's generally between 18 and 23% of insured premium. We're at the bottom of that range right now, about 18%. And the reasons for the financial challenges that we've had are really structural nature about healthcare. It's a reflection of the fact that healthcare and healthcare financing in this country is broken fundamentally. It doesn't work. And it doesn't work for insurance companies. It doesn't work for hospitals. It doesn't work for physicians. And I think, that's the realization a lot of people in the community are coming to. And it's a reason why there's so much, I think there's so much promise about the future, about where we're headed.
You can see sort of the push and pull in the financing inside the healthcare system in Rhode Island. We had the Office of the Health Insurance Commissioner. We're the only state in the country that very heavily regulates the rates, that caps what you can get as an increase. Tim White and I reported last night that Lifespan had another, that Rhode Island Hospital's parent had another fiscal year loss. I mean, is it possible the commission just isn't allowing enough, the commissioner isn't allowing enough money to flow into the system, or do you think there's enough money in it we just need to figure out how to spend it differently?
Everybody's trying to do the right thing. Let me say it that way. The commissioner's trying to do the right thing, the legislature's trying to do the right thing, the hospital's trying to, we're trying to do the right thing. The problem is the system's broken. There's no new money to put into the system to continue to sustain it the way that it's been working for decades. And that's why it has to change.
Nationwide, we've seen this evidence of a slowdown in how fast medical costs go up. There's a big debate. Is it the recession, or have policy changes made that? Is that happening in Rhode Island as well? Do we see a slowdown in how fast costs go up here?
We definitely, part of the reason that we've had a good financial year is because there has been a slowdown in cost escalation in 2013. Now, we had a increase above and beyond what we expected in 2012. 2011 was a down. There's a little bit of a cyclical nature to these things to some degree. I believe, though, very strongly that it's a reflection of momentum that's being built around changing dynamics in the system, both the care delivery system and the financing system. I think we're starting to see, it's really hard to draw the straight line between the actions that we're taking with our partners and those cost trends, but I do believe in Rhode Island and across the country, we're starting to see some of the changes take hold. Some of the changes, like with patient-centered medical homes and the effect that it's having on the way patients get managed. Some of the effect of changing contracts and changing from this perverse fee-for-service system that we have to paying for population health and for quality and for other things that we all want in the system.
Keeping people well versus doing tests.
Exactly.
Yeah.
Instead of more care. The system today, in sense, like every other system, it's perfect in that it incents what it gets.
Yeah.
Right. And it incents more doctors' visits, so we get more of them. It incents, if you're a surgeon, your incentive is to do more surgeries. Mm-hmm. If you're a hospital, it's to keep the beds full. It's not a value judgment. It's an economic reality, and it's the way the system works today, and it's the reason why the system has to change.
All right, we're going to talk much more about that after a break, and we're also going to talk about the rollout of HealthSource Rhode Island, the state's Obamacare marketplace, and the key role Blue Cross is playing in the development of that system. Stick with us on Executive Suite. Welcome back to Executive Suite. I'm Ted Nesi, and I'm very pleased to be joined by a very important man in the healthcare industry in Rhode Island, Peter Andruszkiewicz. He is the president and CEO of Blue Cross and Blue Shield of Rhode Island, the state's oldest and most dominant health insurer. Peter, talking about healthcare, the cost of healthcare, a huge thing on people's minds, a huge debate right now. Rhode Island also has a particularly expensive healthcare sector in the sense that we pay a good amount for our insurance compared to other states. We spend a lot at our hospitals. When you came in and you looked at this market, what drives costs up in Rhode Island compared to, say, Illinois or Missouri or some other part of the country?
Well, Ted, there's two things that I learned when I first got into the health insurance business about insurance in general. One is that, cost, which is the single biggest concern of all of our customers, especially our small customers who have endured really decades of cost increases that are 2, 3, 4 times the CPI. Cost comes from two factors. One, unit cost. What does each unit of care cost? Each doctor's visit, each immunization, each drug, each hospital bed, what is the unit cost times utilization? How many units are used? And we have a problem with both of those things in Rhode Island, as we do across the country. There are two fundamental problems with health insurance and the financing of healthcare in the United States, in my opinion. One is not everybody's covered. And this is one of the things that the Accountable Care Act is intended to solve for. It's the primary reason for the exchanges. But we need to have everybody covered. It's the law of large numbers, and they taught me that in my first day at group insurance school too. If you have everybody insured, you have a perfect bell curve, and if everybody's in the pool, you can set a price that everyone can afford. The problem is there's 50 million people in the United States who don't have coverage,
including about 125,000 in Rhode Island.
Correct. The second fundamental problem in health insurance is the way that we pay for care. This perverse fee-for-service system. It's taken decades to make the system as dysfunctional as it is, and it's going to take some time to fix this. But we know what needs to be fixed, and that's the excitement and the optimism that I have right now in Rhode Island and lots of other places. For years, we've known what the problems have been, but we haven't dealt with them. I think in Rhode Island and a lot of other places, and I think the ACA has created some of this momentum, frankly. People are actually doing something about it. And it's going to take time. There's going to, I always talk to our board about the fact that, we're winding down these perverse fee-for-service incentives as we wind up new incentives around value and quality and population health and all those things that we want. When we build those new models of care, how patient-centered medical homes are going to guide patients through the system, where specialists fit, how hospitals and other pieces of the really fractured system we have today work together and get incented to work together around a patient, we can pay for that too. But when we build those systems, we'll be able to create the financial models to say, no, that's what we want to incent now instead of this old
And it
thing.
sounds a bit like changing the direction of the ship,
Yeah.
a big liner that's going one direction.
And that it sounds daunting when you say it that way, and it is, just to be clear. But I also, like I said, I'm optimistic because I really believe, and I say this all the time, that it's going to be difficult for providers to have a foot in the old world and 1 foot one in each.
Mm-hmm.
That you're going to have to decide. I'm in fee-for-service incentives, or I'm going to the new place.
Mm-hmm.
And we see that with some of our partners already.
And we're seeing a sea change in how people buy insurance, especially this fall and winter going into next year as the Affordable Care Act ramps up. I mean, how big are these changes we're seeing right now from your perspective in this market?
They're huge, and there's two big pieces to it. One is this thing I was just mentioning, the transition from fee-for-service to fee-for-value, a lot of people call it. Rhode Island is, in my view, and I've been a lot of different places in my 30 years in the health insurance business. Rhode Island is the wild, wild west of fee-for-service. I've never seen a more fractured delivery system. In many other places around the country, there's been a coalescing of physicians come together in multi-specialty groups, physicians and hospitals come together in preparation for population health and different. And it's still very, very fractured here. Now, you look at that and say that could be the bad news. I think it's the good news because I think it's a great opportunity for us to create something together, in a way that works for Rhode Islanders. The second major change that's happening is this move to consumerism. So since World War II and the emergence of health insurance, employers have decided for consumers, what coverage do you need? How much am I going to pay as an employer for that coverage? How much are you going to pay as a portion of that coverage as a consumer? That model's being broken, and it's going to change dramatically. We'll experience in our book of business 3x change in our individual customer base on January 1st of 2014. We'll go from 16,000 individuals who buy from us to 40-something thousand is what we anticipate. That plus the fact that a lot of employers are now saying, I'm going to take a more, it's sort of like what's happening in the pension business, defined contribution approach. I'm going to decide as an employer, I'm going to give you, Ted, $200 a month, and I'm going to present you with a slate of options. And you can decide what's best for you and your family in terms of coverage and how much you're willing to pay for it. That's a second change that's really exciting, and it's also daunting to consumers because consumers have never had to make those choices before.
That's going to be the shop exchange. We talked about that last week with Christy Ferguson, and I know Blue Cross is a part of that. We're going to take another break. When we come back, we're going to talk more about these changes coming to health insurance and healthcare in Rhode Island, and we're also going to talk some more about the rollout of HealthSource RI, the Obamacare marketplace here in the state. Stick with us on Executive Suite. Welcome back to Executive Suite. I'm Ted Nisi, and we are having an important conversation about health insurance in Rhode Island and the future of your medical care and your family's medical care with Peter Andruszkiewicz. He is the president and CEO of Blue Cross and Blue Shield of Rhode Island. Peter, let's talk about HealthSource RI. We just saw the numbers yesterday. About 2,700 people have enrolled in private plans as of November 30th in Rhode Island. While they haven't said it officially, I'm pretty sure that's lower than the people running HealthSource RI had been hoping for, and they think a lot of the blame goes to the fact that this publicity is so bad around the whole healthcare law and everything. But what's your take so far on how the rollout is going from Blue Cross's perspective? Yeah,
so back to the original first part of our conversation today, Ted. You know, we believe that all Rhode Islanders need to be covered. It's really important. Everybody needs to be in the pool. And the exchange and HealthSource Rhode Island is the vehicle for that in the state. And so we've invested a lot of time and our resources with the state to make sure it works and it works right and it's available. It's working the way it needs to for the people of the state. We definitely have fewer people than we anticipated at this point. There's no question about it. I think Christy said that on the show last week, and you know, that's disappointing. But I'm not surprised, I guess I should say, especially given the way that things have evolved, both at the state level and in the national scene. There's been so much talk, and there's so little understanding by the general public about what the exchange is and how to access it and who's eligible and what the law is. I mean, the law says that every person in the United States effective on January 1st, 2014 must have health insurance. I believe people in the United States are law-abiding citizens. They want to follow the law. I also believe that if you give a person a choice between having health insurance and not having health insurance, they'll take health insurance every time. And so I think a lot of it's just plain old confusion, number one. Number two is it's about affordability. If they couldn't afford it before, and the subsidies, if they're eligible for a subsidy, doesn't get them to a place where they can afford it, they're still not going to have health insurance. The exchange in and of itself doesn't change the cost of care and the cost of the insurance to provide the care. It's both things that we've talked about here today, right? It's ensuring everyone, the exchange is the vehicle for that, but the cost piece really is about what we do and how we pay providers differently for the services that they provide to consumers. And that's got to be a different kind of collaboration than we've had before. I mentioned before, it's taken decades to make the system this dysfunctional. Health insurance can be put at the top of the list of why it's dysfunctional. That's okay. We're used to it. But it's also hospitals and physicians, and it's the government, and it's employers. And we've got to figure out a different way to work together to create systems of care that are incent things like providers talking to each other about care, about communicating with each other. Many people go see specialists after they see their primary care doctor, and the specialist says, "Why are you here?" And then they go back to see their primary care doctor, and he says, "What did he say?" That's not a system, and it's certainly not a patient-centered system. So we want to create those kind of systems and then incent that, and instead of what we're incenting today, which is essentially piecework. My dad was a union tannery worker. And when I worked in the tannery for a couple of summers to pay for college, and I saw what he did, and he was a piece worker. he would do one thing with a piece of leather, and he'd do it 1,000, 2,000, I don't know how many times a day he did it, and then he'd pass it on to the next guy who did his, the healthcare system today is like that. We pass patients from provider to provider. They do their thing. They try to do the best they can. Everybody's trying to do the right thing for the patient, but we don't incent them to work together. The future of healthcare is team-based healthcare, and we need to incent that.
Now, with HealthSource, I'm wondering about the back end too. We've seen the consumer-facing side of it. Are you receiving enrollments from HealthSource RI yet? Has there been testing done to make sure you're going to get the data you need for people to get coverage?
Yep, we're working feverishly with the exchange to make sure that the back end works. That is going to be the big next test. We're beginning to get enrollment information from them. It's working, and there's a lot of back and forth between our team and the state team, and they're working together really well. And I'm very pleased with the level of engagement, professionalism, that's going on between our teams. I think Christy said it well last week too. We're going to find bumps. We have found bumps. We're going to find more bumps. But we have to make it work, and we're all vested in making it work.
And is the data accurate so far? Mostly, are you finding the stuff coming from HealthSource to you?
Yeah, I mean, what we've seen so far is, again, remember, consumers have until the 23rd of December, and I hope that people who are eligible will go to the website. They can come to our website to get more information. They can come to our new retail store that we opened in Warwick, which we're really excited about, and we have a lot of traction through, and learn more about their options. After December 23rd, we'll see a big wave, obviously, and we'll really pressure test all those systems at that point. And then the open enrollment period goes through the first quarter. So I anticipate a lot of people who deferred or were confused or whatever, didn't know what their options were. We'll see them still come in to the system. We're hoping for that in the first quarter.
Peter, very briefly, about 30 seconds left. Does Blue Cross have any thoughts yet on what the best way to pay for HealthSource RI is going forward?
It's a great question, and there's a lot of people obviously asking the same question. Here's what I know it can't be. What it can't be is to continue to burden our smallest customers, individuals and small groups who are having the most difficult time with the affordability question with more taxes and assessments. Today, those small, fully insured customers pay for premium tax, immunization. They're paying a federal tax now as well. We can't keep loading these fees on those customers that can't afford it.
All right, that debate will continue. I'm so pleased to have been joined by Peter Andruszkiewicz. Peter, thank you for being here with me, and we have much more on WPRI.com about HealthSource RI, how health insurance is changing, and what's happening in healthcare around here. Make sure you check it all out, and I'll see you next week here on Executive Suite.